Good morning, ladies and gentlemen. And at the outset, first, I sincerely put on record my deep gratitude to Dr. Girish and Colonel Srivastav to honor this international symposium on various uses of lasers, both military and non-military uses. Thank you very much, sir, for considering this topic worthy to be attended by you. It's a very interesting and we all are facing issues with the lasers as the application of laser in different part of our life, occupational, medical professions, then in industries, sports and military is coming up. It's becoming a part of our system, and this is going to have, rather it has started coming as a lifestyle or a professional disease. So why it should be attended by each and every ophthalmologist is because it's a silent killer type. The injuries are going to be faced by a mass public, and in those circumstances, it's not the part of the military, even in cases of military operations. Ultimately, the radiation-induced injuries, chemical injuries, biological warfare, and latest these lasers are going to be treated by other than military ophthalmologists and other surgical and radiational professionals. Keeping this in mind, we designed this, and as you are aware of it, we have the galaxy of faculties, those who have done extremely well in their sphere. We have Professor Gaurav Kapoor. I am privileged to be with him for more than a half century, quarter century, not the half century. And presently he is holding the most prestigious professional chair in Armed Forces, that is Professor and Head of Armed Forces Medical College Department of Ophthalmology. Professor Vijay Sharma, very close friend of mine, and young, dynamic, he has been the professor in HOD in FMC, now he is a professor there. He was professor in Army Hospital Research and Referral, though in clinical practice it is considered the #1, but in all domain it is the #2 than the FMC, I would say. And Professor Baranwal, again stalwart. Then we have Professor Shyam Sundar, our young dynamic faculty Tanushri. She is right now is a 10th and 11th, the substitute to the 10th and 11th, but I am sure in near future I will work as a substitute for one of them. And not but the least is my senior and close friend Colonel Srivastav, those who have enough exposure in handling the trauma and operational injuries in armed forces in different parts of the country. With this small background and introduction, may I request Brigadier Shyam Sundar to start the proceedings. Brigadier Shyam Sundar, please.
Good morning, sir. Thank you for your kind words, sir. And at the outset, I'd like to thank you for having included us as part of the IC. When I heard about directed ocular injuries, it brings to mind the various weapons that are used, or lasers that are used in day-to-day life, as well as industrial uses where lasers, as well as energy, which has been channeled into focus beams, are being used. When we have to define directed ocular injuries, we usually say these are electromagnetic energy or subatomic particles which are concentrated and which are focused on distant targets. And these, when you contrast them with traditional weapons, which basically rely on physical projectiles to deliver the payload. These directed energy weapons can utilize any of these forms, light, radio waves, or other energy forms. And delivery systems can be mounted on a variety of installations, right from aircraft, ships to fixed ones. And these sophisticated targeting mechanisms which precisely help direct the energy beam. Applications, if I put it broadly, is a military, medical, and industrial, and each of them have their own uses, right from counter-drone operations to defense uses, and disabling the electronic systems of enemy vehicles, to lasers which we use in LASIK, retinal disorders, and various other subspecialties, especially dermatology. Industrial, especially in welding, cutting, and material processing. If you go by the waves, right from the high power microwaves to millimeter waves and high energy lasers, the laser ones are used in a wide variety of uses, highly focused, and can cause ocular damage at significant distances, while microwaves are used for radar technology and even for active denial systems, where you want to control crowds by using a heat source which causes this to make the patient, the crowd uncomfortable and move away from this place. Particle beams which can cause mechanical disruption to tissues upon impact. The origins of this, if you go to the Roman siege of Syracuse, when Archimedes used a series of mirrors to focus the light on ships, which used to cause fire to them and break off attacks, to World War II, where different DEW programs were used, mainly using X-rays and focus energies. Lasers were used for precision communications disruption, and a lot of this, what I told you about Archimedes, when he used these mirrors, set of mirrors to reflect light. And there was Mr. Rigsby who came up with the electric gun, which had electromagnetic waves to channel the forces. If you take examples of direct energy weapons now, right from what the US is using, the Tactical High Power Operational Responder, or THOR, which can use these high electronic systems and microwaves to target multiple drones, lasers with integrated optical dazzlers and surveillance, which are used on ships and can cause disruption to sensors and potential to harm operators, and weapon systems which are deployed on naval vessels for targeting aerial vehicles. All these have an ocular hazard potential because they penetrate biological tissues, and the cornea and lens especially are vulnerable to thermal injury. Some of these weapon systems, which includes the lethal autonomous weapons also, the laws. And when we come to the phases, the 1970s were the ones where the lasers and magnetic weapons, electromagnetic weapons were used, and a lot of research was done. And after that, the phase of consolidation, and then the Iraq war, where many of these were implemented. So when we come to the first phase, mainly there was funding to develop these weapons. There were some obstacles. Adaptive optics had to be improved. Beam controls and power generations had to be looked into. And in the phase of consolidation, the Department of Defense, the US, had acknowledged them as practical future weapons in 1999. And in 2000, the Joint Technology Office for High Energy Lasers facilitated collaboration among military branches to develop these weapon systems. And these, in the Iraq war, were used to disrupt communication networks, radar installations, and computer technology. Just a short brief on the mechanisms of injury, which can be mechanical effects due to the shock waves, the photochemicals due to the keratitis, and the thermal effects to denaturation. As you can see in the figure, different UV rays and infrared rays that can cause right from sunburns to lens and retina injuries. And these can involve welding arc injuries, medical industrial lasers, as well as microwaves and nuclear blasts and arc welding. Even the laser pointers, there are a lot of work being done. They are usually supposed to be less than 5 milliwatts at the maximum, 1 milliwatt is what most use, but these can also cause macular burns if used in a very irresponsible manner. In just as when the atomic bombs were dropped at Hiroshima and Nagasaki, the radiation retinitis itself was a big issue at that time, and up to a month these people had retinal manifestations with leukopenia. I will not go too deep into laser-induced ocular injuries. The next speaker will be speaking about them. Suffice to know that these themselves cause a lot of changes at the macular level and at the retinal injuries that they can cause, right from burns to dermat, where if the shields are not okay, you may end up with corneal injuries and retinal injuries. The Havana syndrome was about, again, electromagnetic radiation, where they felt that the US people in Cuba reported various symptoms, right from dizziness to cognitive difficulties, and they thought that this was due to radio frequency exposure, but it has been found that most of the time it's mass psychogenic issues that have caused these. And we also had retinal injuries after Op Parakram, where people had actually reversed their laser rangefinder and clicked and got macular burns. A lot of demonstrations which can occur where lasers can be used, so these have also been dispensed with in many demonstrations and gatherings. So far in Ukraine war also they had some countermeasures. So treatment basically depends on cooling, anti-inflammatory, and protective patching when needed, and mechanical disruptions may require surgical intervention. So to conclude, the ophthalmic community must stay informed about these directed energy technologies to anticipate the energy patterns, and also to have educational initiatives to improve recognition and management, and as well as recommend a specialized registry for these injuries to better understand the injury and treatment outcomes. Thank you.
Thank you, Vijay Shamsundar. Excellent overview of and historical perspective of laser and directed energy systems. May I request now Major Anush to talk. She will be talking on behalf of Ankita, a potential domestic source of ocular injuries. Thank you, sir. Thank you. Dr. Ankita Singh talk. Load की कौन कर रहा है?
Dr. Ankita.
At your number is 6.
Serial 6 वाला लो.
ये इन्होंने चेंज कर दिया ना हमारा वो
आपने जो करवाया था सीक्वेंस अलग था.
नहीं यही ठीक है जो हमारा सीक्वेंस में लॉजिकल.
Good morning, everyone. It is a great honor and privilege to me to speak in front of such expertise here. I thank sir for such opportunity to me. Starting with my topic, directed energy is nowadays seen in every home. As science and technology is advancing in such rapid manner, it has nowhere confined to only scientific labs, high research laboratories. It is now seen in every home, and it is an integral part of day-to-day living of humans. Along with these, they have come in advanced gadgets like in lasers, microwave applications, and UV radiation-based devices. However, along with these innovations comes a great potential risk to human eye also in the form of eye injuries. When these occurs only when these gadgets are mishandled or misused. In this presentation, I'll be covering the most common uses, most common causes of such domestic injuries, the most target population, the presentation of patient, and a few case illustrations. As I mentioned, the first target population is children, and the most common source nowadays seen is laser toys and laser pointers. The other common causes seen are mishandling of optical aids like magnifying glass and other careless handling of microwaves at home by the superheated fluids of the dishes. A rare cause which saw a spike in COVID era was the use of UV disinfection lamps in homes and in all regions, which presented with eye injuries in that era. The other second target population is elderly, in which the cause usually seen was solar eclipse gazing and religious sun gazing. The other but rare causes in this modern era are the recreational lights, laser lights in parties, and advanced cosmetics which are used like laser hair removal devices and UV nail dryer devices. And coming to the mechanism of injury, as already explained, it is by photochemical, photothermal, and photodisruption mechanism. And the injury and extent depends based on the wavelength of the energy, radiation power, exposure time, and the spot size. All the laser devices should fit into this criteria, and there are few guidelines set by FDA, and all the laser devices fit in one of these 5 categories. That is starting from class 1 to class 4 in increasing order of the danger amongst them. Class 1, 2, and 3A include the laser printers, CD drivers, barcode scanners, and laser pointers and toys, where the continuous wave is less than 5 millivolts and the injury extent is less, and only injury can occur when mishandled or stared at the beam or if any faulty devices. Class B, 3B, and 4 considers all the laser light shows and high energy devices of industries and research labs, also the military weapons, where even a direct view for a fraction of a second or only the reflected beam also can cause hazardous injury to human eye. Laser pointers and all the toys comes in class 2 or class 3A. Starting with the injury to the eye, UV rays and microwaves mainly target the cornea and lens, as these two tissues absorb most of such energy. And the lasers which come in the particular wavelength of in laser toys and pointers pass uninterrupted in cornea and lens and usually get focused on the retina and causes significant damage to retinal layers. Usually the patient presents within 1 to 4 hours of exposure to such devices, and the presentation can be in the form of central or paracentral scotoma, in form of metamorphopsia, blurring of vision in cases of corneal injury or cataract induction. When cornea is involved, patient can also present with photokeratitis in the form of photophobia and redness and irritation. Starting with the evaluation, as I mentioned, history becomes very prominent in such cases, as in many cases, direct history from the patient is not sought, and digging in only gets us to the diagnosis and the cause. Like the source of injury, the kind of laser involved, and its energy and all the safety guidelines. And also the next comes the symptoms, onset and type of symptoms encountered by the patient. In the investigation modules, the non-invasive tools which help us in diagnosis are the Amsler grid. Then SDOCT is considered as the investigation of choice, which helps in getting the exact location and site of damage. Also with that, the next comes is fundus autofluorescence, where with its principle of concentrating on lipofuscin, the damage due to laser can be seen as hypofluorescence surrounded by a relative hyperfluorescence of normal area. Also, the microperitory can aid in the functional condition of the retinal and the injury occurred. I want to mention few cases. There was a study which encountered a few macular hole cases, which was followed after the accidental laser injury by the laser pointers. This is a case where it was a very past history that the 21-year-old presented with scotoma in his dominant eye, and after digging in, it was got to know that there was an accidental laser injury to his eye. There was a large macular hole, and it was already 8 months of his history. Patient had to undergo vitrectomy and macular hole surgery, but still there was suboptimal improvement in his vision. Another case which was presented with similar laser injury, there was a small hole and it was a very short duration of history. Patient was observed with steroids and topical steroids and just observation. In just 2 months, there was a spontaneous closure of the hole and patient came up with a good vision improvement. The most common cause is the laser pointer injuries, and there is a case report which showed history of scotoma in the patient and accidental laser pointer injury where the fundus showed yellow pigmentation and altered pigmentation. The corresponding OCT showed intraretinal layer damage with edema. Patient was treated with steroids and patient recovered well. In the same manner, there was 2 cases where the history was not very significant. A child presented after 10 years with CNVM and hemorrhage, but after digging in, it was history that there was severe use of laser toys in the childhood. And one more case was accidental laser injury in the party when just a reflected beam also had caused injury. Also, solar eclipse has seen injuries in also children, and also observational studies showed that most of the injuries are seen unilateral in 6th decade patients, and males were the most commonly encountered. As I mentioned, in COVID era, many patients presented with photokeratitis, but all were treated well with and resolved well with topical lubricants and low-dose steroids. Starting with the precautions, only the guidelines should be the proper seeing of guidelines is the mainstay. Children should be kept away from such devices and proper faulty devices should be seen. My key message is such injuries are always to be dug in with the history, and always prevention is the key for such injuries. Thank you.
Good coverage and well beginning through the international debut. See, lasers are, as it has been rightly pointed out by Sham Sundar and Anushri, that we are getting in each and every part of our day-to-day activities. Like you have shown, he has shown that flames with the lasers. Then I have seen even the laser candle in the birthday, on the birthday cake, laser pointers. So that is why we started with in the sequence in such a manner that we go cover common interest first, that she has covered domestic source of injuries. And this is a domain, I think it should have been with me only, because I have done so many iatrogenic laser injuries and other injuries. Sir. Conducted, not Sir. Treated. Okay. So now how to treat this thing and prevent it, I invite Professor Gaurav Kapoor. Sir. Gaurav, please.
Sir. Thank you, sir. I'll be speaking about lasers, iatrogenic injuries and their prevention. There will be a broad overview because actually the outcome and the sequelae of lasers can be massive, and it is actually impossible to cover this in a single session. So I'll be sticking to the ocular part, the iatrogenic injuries, and majorly the prevention and what measures have been taken worldwide for the prevention of such injuries. So basically we all know this, what the word laser stands for, and basically it means you are emitting a coherent light. Ophthalmology, we all know lasers are now taken over most of the treatments because of the uniqueness of the tissue of the eye, that it is a transparent tissue. So lasers have a big role to play in most of the treatments that we have. I'll not cover the physics part of it. The basic problem that we need to understand is the iatrogenic injuries and the treatment, both are related to the property of absorption of the photon. So basically when you are emitting a light, it is the photon which gives you the treatment part of it, and it is the same photon when absorbed in excess or misdirected which causes the injury. So the basic mechanism remains the same. And similar is the emission. So laser depends on spontaneous absorption and emission of the light. So both these mechanisms release energy. So that is where the treatment also occurs, and that is where the injuries also occur. Now the laser construction, we all know it basically has a pump source, a gain medium, and an optical resonator to magnify or target the laser. Now, laser properties, why we are worried about the iatrogenic injuries is because they have certain properties. One, they are monochromatic, they have coherent, they are collimated, that means all the rays are parallel, and they are polarized in one plane, and the most important part is they are high energy. So as compared to normal light, the intensity is measured in joules per second, and they're very high energy. So types of lasers I'll not go through. We are all aware what are the basic lasers used in the eye. This is a list of the lasers that we commonly use in ophthalmology, and these are the ones which actually cause the iatrogenic injuries also. So starting from Nd:YAG, which is 1064, frequency doubled, argon green, diode laser, eximers, femtosecond. These are all used in various parts of or various domains of ophthalmology. Now, before we go into the iatrogenic injuries, if you see, the usage is extensive. You start from the anterior segment right up to the posterior. There's a huge list of treatments that are now done using lasers. So actually classifying iatrogenic injuries depends on which organ you are targeting, which part of the eye you are targeting, and what treatment outcome you are achieving out of that laser. So the hazard list of the FDA has categorized all manufactured laser products into 4 major classes. So class 1 lasers are the non-hazardous. Example, we have the laser printers and the DVD players. They also use lasers, but these are non-hazardous. Class 2 lasers are low hazard, but only when viewed directly for long periods. The common example is the barcode scanners that are used in all shops and our CSDs. These are also lasers, but prolonged exposure causes damage. Class 3 lasers are the potentially significantly hazardous to the eyes with direct viewing, that is the laser pointers, which has been covered in the domestic part. And class 4 lasers are the one which we commonly use, significantly hazardous to eyes and skin, commonly used in opthal and dermat. These are the research and medical lasers, and these are the ones we are worried about because these are the ones which can cause the maximum injuries. So this is the classification that we also use for risk classification of the lasers. Now the laser injuries, ophthalmic lasers have different tissue parameters. They have the same beneficial effect of laser therapy, but they can also cause ocular damage. Basic mechanism of injury is because of the focal magnification or optical gain of the eye, which is approximately 1 lakh times as equivalent to the laser power. Now the risk factors for iatrogenic injuries basically depend on the wavelength, the duration of the exposure, the power of the laser, the beam properties, whether it is a continuous or a pulse. A continuous will have a higher damage as compared to a pulse laser. A direct hit to the eye, reflected beams, or invisible parts of the spectrum. The potential location of the injury is directly related to the wavelength. So if you go by the wavelength, near ultraviolet wavelength 315 to 400, most of it is absorbed in the lens. Far ultraviolet, UVB and UVC mostly absorbed in the cornea. So you get issues related to the cornea. The visible spectrum and near infrared, most of it is transmitted to the retina. So overexposure can cause retinal issues. And far infrared is 1400 up to 1 mm, and most of it radiation is transmitted to the cornea and causes corneal burns. Now this is a long list of the laser procedures and the iatrogenic complications. I'll not go into each of them, but what you will see is what is each part of the eye that you are treating. Say for example, conjunctival lesions ablation. You can cause necrosis, limbal stem cell damage. So it all depends on the amount of energy that you are using and the duration of the exposure and the type of laser that you are using. So at each part you have to be careful and titrate your treatment accordingly so that you do not end up with the equivalent iatrogenic damage. Like for PRK, you can have prolonged corneal haze, epithelial healing delay and pain. SMILE, you can have corneal opacities, incomplete removal, interface hazes. Phototherapeutic correctectomy, you can have thinning and irregular astigmatism because of over-treatment. Nd:YAG, laser iridotomy, we are all aware we can cause hyphemas, corneal endothelial damage, IOP spikes. Nd:YAG laser, which has again been a common laser used for decades now. Overexposure, usage of the laser can cause IOL pitting, cracking, retinal detachment, CME. And similarly, if you see a peculiarity is when you use the lasers for glaucoma, the overexposure can cause IOP spikes, inflammation, which again results in an IOC spike. So basically, you have to titrate the usage of the laser according to the treatment outcome desired. Now, what are the preventive measures? I'll quickly come to this. The general preventive strategies and the specific. The general preventive are the pre-procedural care during the procedure and post-procedural, and specific are specific to the lasers, environment and equipment safety, patient safety, physician safety, and we have to look after staff and bystander safety. So the general strategies are proper SOP should be in place. There should be a patient evaluation excluding high-risk individuals. The laser calibration should be done regularly, and there should be a consent with a risk explanation. During the procedure, use minimal effective to avoid collateral damages. Employ safety measures like corneal shields, pupil dilatation control, focus of the laser, and post-procedural monitor the patient for any side effects of the laser. Now the environment and equipment safety is listed along with the equipment that we use. So a laser device should not be operated if there is any abnormality or abnormal functioning is noted. The instructions and safety precautions should be listed out clearly. Repair, calibration and maintenance, this is the most important, should be done regularly on a timely basis. And equipment should be maintained and inspected. And what is often not done is place a warning sign at any area of the laser usage. So the laser usage area should be clearly marked in any workplace. Again, the appropriate equipment safety, positioning of the equipment. Basically, you need to remove reflective surfaces which can cause reflection of the laser and cause iatrogenic damage as listed earlier to the bystanders or the supporting staff. Again, physician safety is also important. Safety filters are required, safety goggles should be required, and the surgeon should be aware of the hand placement and protection, as the hands are usually the closest to the treatment lasers and reflective surgical instruments. So you can actually cause iatrogenic injuries to the surgeon himself. And staff and bystander safety, they are more vulnerable to hazards due to lack of training or knowledge. So it is the requirement, actually the prerogative of the surgeon to make the staff and bystanders aware of the potential injuries which can be caused. And patient safety protective shields should be worn on the eye not being operated during the laser procedure. So this is just an overview of the broad guidelines that are required and the risk classification of the lasers that are used in ophthalmology. It is actually a very extensive subject. The myriad of injuries or the list is extensive, and each actually requires significant deliberation to cover each topic. I have tried to cover most of it so that we are aware of what the safety guidelines should be in any laser related workplace or environment that we are exposed to. Thank you.
Thank you, Bide Gaurav. In fact, in 8 minutes or so, you have covered not less than 80 minutes input. It's really very high, rich content is having, and the chart is, it must be, I would request my 2 youngsters, and one is a middle youngster, that is so important to go through it. I cut down this thing to my experience with the iatrogenic injuries. My means maybe by me and maybe my colleagues during these things. So we started way back in 80s or so, when we had a xenon arc. The retinal injuries are, you can say how can be dangerous to the extent. The xenon arc had a large spot size. And there are incidences where not only with the xenon arc, I have witnessed in old army hospital, even I've seen in Pune also, that macula is burned. The direct hit on the macula by the ophthalmologist. You can imagine that it has been experienced in our setup also. Outside also it has happened earlier. So one has to be very, very careful when you are doing retinal lasers, that you are not touching, because the patient suddenly moves and you could not control these things, and or you have focused macular and it has come to this. This was very common when we had a earlier in the 2000 the type of lenses for the lasers. Now the lenses quality has improved, and direct imaging is seen, the reverse imaging has definitely. So this is one of the major concern what I have. I remember one case which had a synechia, uveitic cataract. So when you are moving like the entry segment lasers, when you are focusing, you must ensure that laser is on the rest. It is on the off position, not on the on position. On position only when you have focused it. I have seen that the laser has created traumatic cataract. It has happened in R&R somewhere in 2008 or 9. The laser had put into one of the Subedar Major's wife. I still remember that. So this is this possibility. When you are making the iridotomies, the peripheral iridotomies, it gives iatrogenic injury to the lens. All of us would have seen cases of the PI cases when you are operating. There is but it is a negotiable. It's not a deep as this thing. So you may, if you have used high energy, multiple points, and this can lead to the cataract formation. This is another point which one will see. Posterior capsular opacifications doing for PCO, IOL pitting, yes, it is very common. But other than that, what I have seen in the 98, 2000 with the early lasers in FMC, those days was the days of the PMMA lenses. So the iris, this IOL pitting in normal lenses, it's just a small these things. But there it was a crack.
PMM is crack.
There was a crack and the fragment of IOL went into the posterior segment. Higher energy used for the PCO had developed retinal detachment. I have seen for doing for the PCO and the patient has developed these things. The macular edema is very common. When you are handling with the children in the lasers in the surgical procedures or in the ROP cases and all, be careful. So these are for the day-to-day practices and ophthalmology handling with the laser. We must know that all whatever has been documented here, it is factual, and whatever has not been documented, what I have experienced with the lasers. I did my first laser way back in 1995, the green laser, when it was placed in the army hospital by under this thing, leadership of Brigadier P.R. Sen. So since then we have been seeing, watching. So laser is a good, we are using in all practices, in our all part of the ophthalmic these things, and it will keep on increasing. But be careful that, and another word of caution which I have started doing it now with the PCO cases, please ensure and get it confirmed on the OCT. That you are thinking that this is because of PCO. But you must analyze that the PCO, the visual loss is, compromised vision is commensurate with the PCO.
Yeah, another issue which is...
Since it is a service,
yes.
Only 3 service officers are there, so I can speak as a senior consultant surgery also. So I am doing in all my cases before laser, reconfirming on OCT. Because in last 6 months I found in 2 cases where I did not do OCT, one of them found to have the macular hole and another had a macular edema, CNVM. Otherwise the patient may sue you that because of the laser you have done this. So be careful. When you don't take it as a routine affair and light affair.
If I may add, sir, the issue with PCOs now is actually there is a higher risk because of the newer design of the lenses. Lenses are now have a convexity, and the square edge and the optic design ensures a better contact of the posterior surface of the IOL with the posterior capsule. So actually the safety margin between the PC and the IOL is much lower now. So your safety margin for a PCO has reduced actually over the earlier lenses.
Yeah, absolutely. So what setting you are keeping, Gaurav, for PCO? Off setting? Posterior offsets. 125 or 250 micron? 125 posterior. Earlier we used to keep 250 with the PMMA lenses, and the energy should be as least as there. Somewhere around 1.2 or like that. Thank you very much, Brigadier Gaurav, for giving such a wonderful insight. And now I come to which is supposed to be the armed forces related issue, lasers and direct energy as a military weapons and its impact on the eye. It's a real eye opener. That's how the laser systems are being used. I think this slide was basically meant for the non-military group of the ophthalmologists. When you think of war or you think of any army person, you always think that he is having a gun or a pistol in his hand and shooting every time. So the war also, that in any this, the eye injuries may be because of so many reasons, but you see that less than 35% of the total of the war trauma is of the ocular or the polytrauma related with the eye. Now, what you see in an operational area, those who have gone, deceased, their data is not available. Let it be very honest, because multiple injuries and all. A good number of cases would have been handled by RMOs or the field hospitals. Their data are also not available with us. Those who are coming to the service ophthalmic centers, their data is available in our country, and we have a tendency of keeping everything under carpet, whatever whether it is your data of the clinical practice, military warfare, so-called, and your mistakes also put under carpet, concealing things. But in the Western world, after some time, the data are available. So the most of the war data, operational injuries are coming up from the US. They are more liberal in these issues. In military system, there may be operational injuries, there may be non-operational injuries. Operational injuries are maybe the war injuries or the training-induced injuries. So these are the different types of injuries you can see. Armed forces functions not only on the ground, air, sea, submarine, and now in space too. So the horizon is becoming too broad to have, more you have the gadgets, more you have a sophisticated, more you have a trouble. A simple 20 years ago, you go to bank to get your bank statement, the passbook would have been filled. Today you go, if there is a interruption in the internet, you will not get anything. The same in the airport, the same in every system, that it gets to standstill. So more we are technology oriented, more problems are coming. The same way, the modern warfare systems are highly complex and they are giving all kind of problems. Radiation, biological and chemical warfare induced impacts may be much more significant than those away from the main operational areas. So laser, electrolaser and direct energy weapons induced ocular trauma is a newer threat, and probably our young generation, those major and young lieutenant colonels, when they become senior brigadiers, this will be the larger volume of the ophthalmic injuries you will be seeing. Within 5 years you will change, though there are a lot of restrictions on the lasers in the different convention by the United Nations. But as usual, who believes and who bothers about all this? I won't accept what I am doing it, but everybody is doing it. Let it go with that idea. If I am not doing it, any laser weapons, etc., but I must know how to prevent these injuries. And for that, I have to develop a system which is against it. If you have to develop a system against it, you have to have the system first in your hand, then only you can counteract. Let it have this concept in mind. Yes, we may not be using it for the operational purpose. Laser weapons have been a staple. Now this is a science fiction. In my early school days, whatever was there, that Phantom is coming and all those, the James Bond pictures in 1970s, he had a special car, he had a different coming, but now it is a reality. And that reminds me, in one of my hostel classmates, he was a little lazy type. So what he did is, his room was on the second floor, so while sleeping, he put that one small, this nada called there, in his nose, and it was stick with the door. If door is not later he used to do like that. So like this Pushpak Viman and all those movement hand. Now it is reality. The movement hand, you have this, this is opening. Before I go to it just clicked to me about the iatrogenic or the non-operational, these laser scans, whatever is coming in the airport. Though they claim that is they are very safe, but who knows what is the limit of the safe. Not of the part of it, but it came, so I said I must put it there. Nations around the world are rapidly developing high energy weapons for military missions, as I mentioned. Vision of swarms of small expensive drones filling the sky, all those are now in the realities which is coming. Normal circumstances, you use the high power laser systems to cut through the biological tissue in medical or in the medical procedures. We are using so many lasers in soft, small tissues, but in the other surgical domain, they use a very high intensity laser procedures are being performed there. On the same way, the power level of the lasers for the different practice will be much different. In the laser weapons, the based in the part on the progress made in the high power industrial laser. So things started with the industries, cutting the these metals and all other cementing, everywhere the lasers are being used. So with that we got the idea to go with the laser weapons. The high energy laser systems that are finding military applications are based on solid state lasers. So neo-DIMM is the backbone of all those lasers systems, whatever is coming. And in ophthalmic practice, like the femto lasers, that is also the solid laser. So from these crystal particle lasers, the orgone lasers, now we have switched over to the solid laser. And these solid lasers are all military weapons are coming up with this. We don't know. Some conjectures are there, like in the Iran-Iraq Gulf conflicts. The hitting on these Osama and then the General Soleimani by the Americans, it is presumed that the laser weapons were used in that case. We don't know about Galwan, what has happened, that sudden melting electricity, all those by the Chinese. It may be one of those experimental, we don't know, nobody knows about it. It will never come on these things. So there are different these things. The Navy has deployed a ship-based high-energy lasers to defend against small and fast-moving ocean surface vessels. So it is coming up. On the same way, the US Air Force is also developing high-energy lasers on aircraft for defensive and offensive missions. In 2010, Air Force tested it was as a 60 megawatt laser mounted on a modified Boeing 747. So you will see that gradually this is appearing. And there is a claim that in the Ukraine-Russia war, these laser weapons may be used, they would have used it. What about the China and other countries? We don't know about it. For us, yes, it is a significant threat to the vision in modern military operations. Operations are based, MICE is a 10-minute talk, not 8 minutes. The earlier concept was of the mortality, but now it is a morbidity, the multiple morbidity, and easiest to make somebody blind. A small hit, but then he is off the activities. So that is why the significant threat to vision is the main target for the military operations in different type of gadgets is coming up in these things. This has already been covered, laser classifications. Now how it is related with the ocular trauma, there are the factors of the power, then there is a wavelength and color, they play a factor for injury thresholds. Green wavelengths are more easily absorbed and therefore cause more damage to the retina compared to the red wavelengths or equivalent power. Again, there is a duration. How much is the duration? Energy settings. This is very important things and Gaurav has already covered, so it is applicable here also. Then in the direct energy induced accidental exposures to the NDEAC is most risky, and this is happening in military setups. The other is the retinal hemorrhages, retinal swellings, macular edema. All those are seen in our cases here. If you go with these things, the laser injuries, by and large, it will be common as the iatrogenic injuries. It is because it is intended to produce the morbidities. But in the higher energies may produce retinal and vitreous hemorrhages due to absorptions of radiations by the melanin-rich retinal pigment epithelium. Foveal lesions, more common because moment there is a flash, the eye will look into the flash and the foveal lesions may come. So laser injuries are by and large, they are the smaller than the radiation injuries due to the nuclear blast. But the pattern would be the same type of pattern. And obviously other than that there will be the, if the object is away from the main target zone of the laser conflict, then the impact may be less, and the delayed effects of the laser lesions, and ERM, radiation-induced retinopathy, scarring, etc., retinal holes, detachment and delayed blindness may also be seen. These are the symptoms being attacked by the direct energies. So anything which you can think of may be the part of the direct injuries, because the neuropsychological disorder, psychological issues, headache, nausea, vomiting, vertigo. So you have to see that it is not only the patient will come only with the standalone ocular injuries in the laser warfare system. There will be multiple, and our part will be one of that associated with disease. And yes, significant loss of weight, muscular disabilities, and major and fast hair loss. This could be also due to the radiation effects. To conclude, military laser weapon systems are becoming indispensable in most modern armies. These lasers have outplaced research on eye protections measures which continue to have inherent limitations. Eye injuries caused by military lasers are increasingly reported, leading to speculation that these would become an important cause of binding in modern conflicts. As a part of the efforts to ban inhuman weapons, international laws have been passed to restrict the proliferation of such binding weapons. But as I have mentioned, who cares about it? So you have to face this music. However, there are controversies concerning the interpretation, implementation and effectiveness of these laws. The ophthalmic community can play a greater role in highlighting ocular morbidity from military lasers and in preventing their future proliferations. Thank you very much.
Thank you, General Parihar, for lucid presentation on the use of lasers in a war setting. Actually, one doesn't know what all countries are preparing, using and all those. So it is just a speculation that one can tell, but countries are spending a lot of money for use of lasers in the war setting. Thank you, sir.
Thank you. Now I invite you to present your
First of all, I must thank General Parihar sir for giving me opportunity to present this topic. General Parihar is not only my teacher but guide and well-wisher as well. Thank you, sir. My topic is dynamics of microwave as a source of ocular injuries. I have no financial disclosure. As far as the microwaves are concerned, as have been pointed out, these are electromagnetic radiation characterized by specific wavelengths and frequencies. The wavelength ranges between 1 millimeter to 1 meter, and the frequency ranges from 300 megahertz to 300 gigahertz. Microwaves are commonly used in household microwave ovens for cooking of the food or for reheating the food which has been prepared. In addition, it is commonly used for in the wireless communication devices like internet and the mobile phones. In addition, they are used in the radar technologies. As far as the industrial heating is concerned, the microwaves are used in almost all of the industries which are useful for us, starting from the paper industry to chemical industries, petrochemical industries, the ceramic industries, the cloth, furnitures, you name an industry and these are being used. The point is how does these microwaves, they damage the eyes? The interaction of the microwaves with the biological tissues mainly occurs in two ways. First is the thermal effects. Thermal effect is supposed to be the most important effect, and cornea, being rich in water, absorbs microwave radiation and heats up. In addition, microwaves, they penetrate the eye and may heat up the lens also. Eye sensitivity, is, especially the lens and the cornea, are more susceptible to damage by the microwaves due to poor heat dissipation. In addition to the thermal effects, the non-thermal effects are also supposed to damage the eyes, though they are less well understood. Microwave-induced electrical changes can occur and damage the retina, cornea and the optic nerve. In addition, the microwaves can disrupt the ionic balance and electrical signaling of the cells, especially of the retina, causing retinal damage. Oxidative stress because of microwave radiation has also been implicated, leading to inflammation, cell damage and degenerative changes, especially of the macular area and the retina. Specific effects of the microwaves on ocular tissues are on the conjunctiva, then it may cause dryness of the eye, it can cause damage to the cornea, it may lead to cataract and retinal damage. As far as the risk factors for ocular damage are concerned, not all microwave exposure, they leads to eye damage. But for eye damage, the risk factors include the intensity of the microwave radiation. The more the radiation intensity, the more is damage. These are especially seen in the industrial settings where there is more exposure to the high microwave intensity. Then direct exposure of the microwaves, especially the malfunctioning of the microwaves or high power radar systems, it increases the risk of ocular damage. Then prolonged exposure of the microwaves compared to the short exposure is supposed to lead to more eye injuries. Types of ocular injuries, there can be thermal burns, or it is also supposed to cause endothelial cell damage because of the increase in the temperature. Similarly, cataracts because of the denaturation of the protein, because of the thermal effects, cataract is supposed to be common. Retina, as I told you, it is the microwaves are also supposed to damage the retina because of the penetration and coagulation activities leading to vascular occlusions and retinal damage. These are also supposed to be common nowadays. Then dryness because of the long and prolonged exposure, repeated exposures, dryness of the conjunctiva and cornea can occur and leading to dry eyes. Similarly, conjunctivitis, one may have inflamed eyes because of the chronic exposure to microwaves. Prevention and safety measures, these are common for almost all types of exposures, radiations. One has to use protective eye gear as recommended by the companies for the use of the microwaves devices. One has to maintain safe distance from the point where the microwaves are produced and follow safety guidelines which have been given with by the manufacturers. Another important thing is the device which is producing the microwaves needs to be checked regularly and calibrated so that accidental exposure does not occur. Shields have to be used which have been prescribed by the manufacturers. To conclude this topic, the microwave biodynamics is important because we need protection, and we must know what all damages can occur to the eyes and the body because of the microwaves, and these should be, it is an important for awareness and prevention measures. Thank you so much, sir.
Thank you, sir. You covered the microwave aspects beautifully. Compared to lasers, microwaves also cause injuries, I think, on a similar spectrum. And it is just that we haven't talked about it much, that microwaves can also cause similar injuries, and awareness of this is actually lacking in the population. Thank you so much, sir.
Thank you, sir.
I request Anushri to speak on microwave inflicted operational and industrial injuries.
Once again, a very good afternoon to all of you. Most of the topic about microwave is covered by my senior, pointing to the few aspects which are important in view of operational and industrial hazards seen. Microwaves in industries and industrial region mainly seen in radar systems and medical equipments and treatments. The other most common, but also not in industrial level, but in a higher hotel management level, is seen in microwave ovens. Though even after many guidelines are taken at every stage, in the manufacturing stage, in the organizational level, and in the ground level, even with this much care taken, many cases are being reported with hazards. Usually, I think it can be taken, it is all just because of the carelessness in handling and less awareness amongst the workers while they are handling such highly energy devices. As already discussed, the effects usually will be the thermal effects and photochemical effects, and cornea and lens are the most commonly injured part of the eye. And the extent of injury depends on the intensity and the severity of the energy. The mechanism of injury goes like this. Because of the microwave radiation, there is heat generation which causes thermal damage to the ocular surfaces. And because of this raised temperature, there is chemical injury, that is denaturation of proteins. Finally, in the lens, it leads to cataract formation because of protein denaturation and decompensation. And also the corneal decompensation occurs, and also with epithelial burns, and patient presents as photokeratitis. When the energy is very high, but in rare conditions also can damage retina and the optic nerve because of the very high radiation. Patients usually present with photophobia, redness and watering. When the posterior power segment of the eye is affected, and patient can also present with blurring of vision, metamorphopsia and scotomas. Starting with the evaluation, detailed history is very important, and the exposure time and exposure duration is very important in this kinds of injuries at the industrial level. After this detailed slit lamp examination and posterior segment evaluation by fundoscopy, few investigations will aid us, like fluorescent staining helps us to see the extent of corneal burns, and this is the picture showing superficial corneal burn and the fluorescent stain taken up by the damaged epithelial region. And in the slit lamp examination, this is a picture showing the sudden onset of cataract formed after a brief exposure of this high energy in an industry. The equipped investigations like OCT and electroretinography helps us to see the functional and anatomical status of damage to the retina. I want to mention few cases at industrial level and also at domestic level caused by injury due to microwave radiations. This was a case where a 39-year-old engineer, while his work in the radar platform, he got exposed to microwave energy because of his negligence and not using the protective wear. Where in the first day there was no much of the findings encountered when he visited the ophthalmologist with complaints of irritation and mild blurriness of his vision. But over a period of a week, he developed anterior and posterior subcapsular cataract, and over a period of 15 days, it progressed to such an extent that this young engineer had to undergo a phacoemulsification surgery and intraocular lens implantation for this negligence. And subsequently, he was under follow-up, and also patient developed severe macular edema, and this was suspected that because of the high energy which he was exposed, that posterior chamber was also affected, but it presented a bit in a later condition. But thankfully, patient was recovered well with topical steroids and also initial dose of oral steroids for his macular edema. One more case which was encountered in a five-star hotel was a worker when he was working with a big microwave machine, and just because of his negligence and he didn't operate the machine properly, when he opened the microwave door which had a very superheated liquid in the dish, he sustained injury to his ocular surface, leading to stem cell injury also. Patient presented with periorbital edema, severe chemosis, and severe injury to his corneal epithelium. Initially, he was treated with lubricants and topical antibiotics, but at later, patient ended with severe limbal cell injury, which he had to undergo limbal cells transplantation for the same. Though it is out of this subtopic of industrial and industrial level, I want to quote two cases which had happened at the domestic level, that old age person, he was using water and he mixed Vicks Vaporub normally used in the domestic purpose, and he heated it in the microwave. Accidentally, without proper precautions, he opened it and there was splash of that fluid into his eye, which caused injury to his ocular surface. Patient had to undergo amniotic cell transplantation, and also with that blunt trauma with this heated fluid. At a later stage, patient also ended up with phacomorphic glaucoma and also bullous keratopathy. A child, because of mishandling of the microwave at the home, sustained injury to his ocular surface. Patient was managed with topical steroids, and he also ended up having pterygium, a permanent corneal scar, and a symblepharon formation. Starting with going generalized with the treatment, as sir already mentioned, it is pain management with analgesics, copious use of lubricants, and low-dose steroids at some extent also needed. For corneal burns, it will be low-dose steroids and antibiotic cover-up. When cataract is to such extent, patients might also need cataract extraction. And for retinal damage, it will be topical steroids, and if there is any disruption, surgical intervention also necessitated. Starting with the precautions, the protective eyewear in industries, it should be a proper eyewear, proper distancing from the high energy devices, and proper shielding is needed. Proper regulations should be followed in every industries to prevent such mishappenings just because of lack of awareness. Proper handling and servicing of the industrial equipments are needed. Thank you.
Thank you very much for nice presentation and keep it up. Ultrasonic, microwave, they are going to be frontline weapons followed by lasers in due course of time. So one must know that because these are silent weapons. Creates enough nuisance slowly, but it is not visible. So that anything which is not making any noise and creating more nuisance is most welcome now. Unconventional warfare is better than the direct confrontation. So that is why we thought of this specifically designed instruction course was aimed to sensitize that it is not only the military but non-military applications of different, like the Havana syndrome, which is means very few years ago it was a big talk. Is something like this ultrasonic injuries only. I think amongst all speakers, the most difficult topic where I was totally confused and how to handle in less than 8 minutes. I found that only one sensible person among all of us who is highly meticulous with his quiet attitude and exposure as an editor in MJFI is the most suitable for this task of evaluation of laser and direct energy safety program.
Thank you,
As the IC is very dry and this is icing on the cake, the extremely dry part, but the most important.
Sir. Thank you. Thank you very much, sir, for the introduction. So I'll be covering the various aspects of safety programs, which should be how to implement them. This will be the overview of my presentation. The objectives of safety programs, what are the safety standards which are available, what are the implementation strategies, what are the challenges, and how, what are the future directions and innovations. So as we know that I think this part has been covered very well. So the video on the right side of the screen is just 5 milliwatt laser with continuous exposure, how are the effects, and the video on the left side is 5 milliwatt laser. And you can see the effects of a 5 milliwatt laser that it can cause burning, it can cause cutting, and if we go to the military use of these lasers, then it goes to even 100 to 1000 times of this power, which can subsequently lead to extensive damages, be it the drones, be it the aircraft carriers, and be it the satellites. So lasers are highly focused, pointed beams with very high energy, very accurate. So that is why they are finding the military use nowadays in excess. And a lot of research is going on in every country to develop the laser-based military weapons. Now, this part has been covered earlier to some extent. First of all, we have to know what are the various classes of the lasers are present. So, as has been covered, that class 1 lasers are, which are very safe under normal use for everyone, even if you are viewing them with optical instruments. Then class 1M are the ones which are normal viewing condition, they are safe. But when viewing with the optical instruments, they become very, they can be hazardous. Class 2 lasers are all visible lasers. All visible lasers, the advantage of visible lasers is that they can induce a blink reflex, and that can cause the, that can give a safety, safety factor. So class 2 and class 2M, class 2 lasers less than 1 milliwatt, and class 2M laser, which are safe under the normal viewing but can be hazardous if some optical aids are used. Then class 3 lasers, again 3R and 3B. 3R is 1 to 5 milliwatt and 3B is 5 to 500 milliwatt, and class 4 lasers are very high power lasers, more than 500 milliwatt. So when we started preparing for this topic, it was actually thanks to General Parihar sir that we could see our lasers, and we just try to find out what are the various insignias or what are the various labeling of our lasers that is there. So we went through the YAG lasers, 1064 nanometers, what are the various signs or danger signs or what is written on them. And I'll come to that because that's very, very important part of the safety or a prevention program. So this is a frequency doubled ND-YAG. So that is where the importance of safety programs comes into being. to prevent the accidents, fostering a safety culture, and setting the clear goals and regulatory compliance. Very, very important. So, which are the standards which guide all the laser machines or equipments which are presently available in our country? So, these are the BIS standards of IS 16071 of 2013. Now, these standards are aligned actually with IEC standards of 60825 of 1. Now, aligning provides these actually a global safety benchmarks. Now, what do these standards and how do these standards evaluate the various machines? Every machine hazard analysis has to be done and the risk assessment has to be done. Hazard analysis is done by two factors, that is accessible emission limit and nominal ocular hazard distance, and also the risk evaluation. So, there are some engineering controls and safety features which have been specified for these machines. Now, what are those engineering controls? That every laser machine should have a protective housing. That protective housing is very important to prevent the laser radiations from exposing the individuals around. Then second is every laser should have a laser switch on and off key. So if you see all the laser machines which are available with us, they have a key available in that with which you can switch on and switch off your laser machines. Third is the beam stop and attenuator. So this is an inbuilt mechanism which decreases the exposure or that blocks the laser emission in case of required. And then there is an emergency shut-off switch. Now this is also available on every laser machine or equipment which is available anywhere, be it medical laser or industrial lasers. So these engineering controls and safety features are must. So all of you should see actually with your machines whether these compliant features are available or not. So laser, especially the laser switch on and off key, as well as the emergency shut-off switch. Then the next part of these standards comes the administrative controls and operational requirements. So administrative controls, so every laser machine should have a laser safety officer nominated for that. There has to be SOPs. The access control has to be into the laser machines which are located. There has to be training and education, and also any incident, if it happens, that has to be reported. Then these warning labels and signages, again they are available on every laser machine. The first one, that is a star burst pattern. So that is the basically label for any laser machine that is available on all types of laser machines. Then depending upon which class the laser is, whether it's a class 3B or 4, then a danger sign is put, and if class 2 and 2M, then a caution sign has to be put on that laser. And also the classification labels have to be there. Then there have to be beam enclosures. The access to the laser room has to be controlled. So it should be the controlled areas. The ventilation and exhaust system have to be proper, and electrical safety has to be ensured in the laser areas. Now let's see our lasers which are available. I think all of you have got this Nd:YAG laser. So now the most, I think one of the major mistake that everyone does is that they start using this Nd:YAG laser as a slit lamp. By using the Nd:YAG laser as a slit lamp, because it has got a good lighting, so it's kept in a OPD. So once it is kept in the OPD, the first and foremost thing of access control to that room, that thing is compromised. So it's not recommended that you start using the Nd:YAG laser as a slit lamp, because then the access control, then you are violating all the regulations which are available. Secondly, as Parihar sir has told, that there was a case of cataract that happened following exposure to the Nd:YAG laser. So that happened because those regulations have been violated to some extent, which have to be adhered to. So that can happen. So that is why using a Nd:YAG laser as a slit lamp in a no access control area, that is in OPD, is not recommended. So it should not be done. So that access control areas have to be there wherever the laser machines are kept. And also all these labels have to be ensured and seen that which class of laser it is, Does it have that access key? Does it have that on and off key? Does it have the emergency stop which is working or not? Once this all is ensured, then it's safe to use these lasers, and all these regulations have to be adhered to. So I think with this I conclude. Thank you very much.
Thank you, Vijay. You've covered an unknown aspect of the lasers. I think he himself admitted this is something he had not read about earlier, and this forced him to actually go into it and look into the safety standards and regulations which are actually available, and none of us are aware because we don't go into these details. We just get an equipment and we start working with the equipment without looking into the safety aspects.
Yes.
So,
So
with this
it was actually by inclusion in this IC, it was an eye-opener for all of us, at least for me. I went around all the machine, I checked what class is it available, are we adhering to the BIS standards or not. So there are so many things we learned just because of inclusion in this IC. So thank you, Parihar sir, for that.
No, I knew that who can do justice to what topic. And I am a deep admirer of Vijay for his academic excellence. Very pleasant person, very quiet, extremely professional, and the way he has published article in journals where I could not publish, so I understand his caliber. That is why he was chosen, and though I am not his enemy, but wish he would have become chief editor of MJFI.
Thank you.
Any surgeon you ask him to take this job probably, but the Armed Forces, Medical Services and MJFI would have been highly benefited by his presence. I have no doubt about it.
Thank
so
you,
I
sir.
wish you sometime the chief editor of IJO, and it will happen.
Thank you, sir.
All speakers have done justice to the task assigned to them. I am deeply obliged and grateful to each and every one of them. We work together, we face problems together, solve problems together, and all seniors, probably you may not be knowing the Major Baranwal, how good he was, or Major Shyam Sundar, Gaurav, they all, I had a privilege to see them as a trainees, advanced course officers, but each and everyone has taught me. Bandyopadhyay, we had an update in 2001, so Bandyopadhyay and Gaurav, they were backbone, Anirudh. So gradually everybody grew. I am sure Mohini, you and Anushri, you will also grow in due course of time. I was, as per the IQ is concerned, the very average IQ as compared to all of you. So I have enjoyed my stay in the armed forces to great extent. So I know you have better chances, better wisdom. So sky is the limit. Be honest to yourself, be honest to your profession, your organization, and patience. Things will come in due course of time. 10,000 run doesn't become in one day. It takes years to come. So sustain continuous efforts with sincerity will give you each and everything. Thanks a lot for joining us as a part of this instruction course. Though number is less, number game matters, but quality matters. So those who have attended, their quality of wisdom and sincerity and concern about the topic, that matters a lot for all faculties who are here. So I am deeply touched and honored. Thank you very much.
वो